Welcome to today's webinar from the International Alliance of ALS MND Associations. Our topic today is respiratory support in ALS MND. For this webinar, we have English and Spanish captions available. If you're joining us live on Zoom, please check the chat box as we are adding the instructions right now, or scan the QR code on the screen if you have another device available. And if you're watching the recording in our YouTube channel, you will find the instructions in the video description on how to activate the subtitles. Para este seminario web tenemos subtítulos en inglés y español disponibles. Si se unen a nosotros en vivo vía Zoom, verifiquen en la casilla del chat, ya que estamos agregando las instrucciones en este momento, o pueden acceder a la traducción por medio del código QR en pantalla usando otro dispositivo. Si están viendo la grabación en nuestro canal de YouTube, encontrarán las instrucciones en la descripción del video sobre cómo activar los subtítulos. For this webinar, we are using automated captions. Please bear in mind that this kind of translation is not perfect and many variables can affect accuracy, and errors are possible. However, if a few words are incorrect, you should still be able to get the meaning in context. Thank you to our sponsor, Mitsubishi Tanabe Pharma, without whom this webinar series would not be possible. For those of you who don't know me, I am Jessica May, Programs Coordinator of the International Alliance, and I am joined today by an incredible panel. We will hear from Angélique, who will share her respiratory experience since her ALS MND diagnosis, and from Susan Brumby, who will follow her, taking on quite the task of covering a lot of content on respiratory support in ALS MND in the brief time we have. Let me tell you more about them. Susan Brumby is the founder of Respire Tasmania and a dedicated physiotherapist with over 10 years of experience in managing complex and neurological conditions. Her expertise extends to providing essential care in intensive care and acute settings. Recognizing a significant gap in specialized respiratory care, Susan established Tasmania's first practice focused exclusively on respiratory physiotherapy. Susan is renowned for her innovative approach, combining advanced therapeutic techniques with personalized patient care, setting new standards in the field. She has shared her insights at the Allied Professionals Forum in Basel, Switzerland, and continues to champion respiratory health, working closely with organizations such as the Motor Neuron Disease Tasmania, Paraquat Tasmania, Muscular Dystrophy Tasmania, and Huntington's Tasmania. Susan's dedication is driving Respire Tasmania to the forefront of respiratory health, ensuring every breath matters. Joining Susan, we have Angélique van der Leet. In February 2018, Angélique was diagnosed with ALS. Angélique is part of the Patient Advisory Council for ALS patients in the Netherlands and UPALS. As a member, she represents the voice of patients living with ALS. Angélique has always had a passion for music and traveling, and despite being in a wheelchair, she continues to enjoy both. Angélique lives in the Netherlands with her husband and 2 children, and until 2021, she worked as a manager in the town hall, busy with inhabitants and staff. By joining the International Alliance's ALS MND Association's People Living with ALS and Caregivers Advisory Council, which we refer to as the PCAC, Angélique hopes a cure for treatment for ALS can be found faster. Now, some final instructions. Any questions you have for our panel, please write them in the Q&A chat in Zoom. I also want to take this opportunity to thank everyone who has submitted their questions. There is a lot to cover, and we will do our best to answer as many questions as we can in the time we have. Now, I will let Angélique share her experience with us, and just give me one moment while I will start the video. Just one moment.
After 9 months of struggling, I got my diagnosis ALS in December 2017. In September 2020, I was admitted to the hospital to set up my night ventilation. It was a bit unexpected, but after I developed pneumonia, I really needed it. The admission and adjustment would take place in 4 days. I can tell you that it was scary to put on a mask for the very first time and completely surrendering yourself to a machine is really exciting, but with some help, it was very easy. We also learned to use the airstack balloon. Unfortunately, I also needed more air during the day, so I got also this mouthpiece with ventilation. After 3 days, I was allowed to go home. I think that thanks to my ventilation, I've been reasonably stable for 3 years now. All in all, the ventilation has improved my quality of life, and I count my blessings every day. I wish you all the best.
Angélique, thank you so much for sharing your experience, and I'm sure there's a lot of questions that will come up and we'll address in the Q&A, so please feel free to ask Angélique on the chat. She'll also be looking at it. So Susan, I will pass it over to you now.
I do need to unmute myself. Where am I here? Just bear with me. I'm still relatively new to Zoom, but we will get there. How's that looking, Jessica?
Perfect.
Beautiful. So I just want to say thank you for Jessica for asking me to do this presentation and to have a talk about respiratory support in ALS and MND. I'm really blessed to be able to come and do this for you all. So in this talk, we'll be covering essential aspects of respiratory care to the best of my ability in the timeframe that we have. It is obviously it's a very complex and very large conversation. So I've just kind of nutted it down into what we feel is some really important areas. In some areas it may feel a bit brief, but put your questions down in the chat box and we can definitely expand on them a little bit later. So the goal of this presentation is to provide you with a comprehensive understanding of respiratory management, things that are important to consider when working with the respiratory system and the decision-making around different treatments. So the topics that we're going to cover today are breathing in ALS and MND and how it's affected and impacted, symptoms of respiratory compromise that people may experience, self-monitoring and formal monitoring tools that can be done obviously yourself or through your professionals that are working with you, the management of oral secretions, respiratory muscle training, cough assist devices, mouthpiece ventilation or SIP ventilation, And Angélique hopefully will give us a little bit more insight there. Non-invasive ventilation, tracheostomies, and the management of secretions on ventilation. And then obviously we'll go into a bit of a Q&A. So to kick off, as we're aware, ALS MND impacts on all of the muscles within the body, and the respiratory muscles are not excluded in this. So it's good to understand that our primary breathing muscles are actually the diaphragm and the intercostals. And second to that, as we exhale, at rest, our muscles the diaphragm and the intercostals just recoil passively. And I explain this like, as you take a deep breath in, your muscles contract, but as you let go, it's a little bit like dropping a rock and it just kind of falls on its own accord. We also have the accessory muscles to breathing. So for inspiration, we have the sternocleidomastoid, and these are ones that are found around the neck and as well as the scalenes. The pec major and minor are found at the front of the chest. Serratus anterior actually found on the shoulder blade, and they attach onto the rib cage. The internal intercostals are found between each of the ribs, and then your lat dorsis are a big muscle that are found on the back. We also have more muscles. So we have accessory muscles too when we exhale with some force. And these are also quite important to when we try and do a cough. So we have your rectus abdominis, or you might know them as like your six-pack muscles. And we also have external oblique muscles, which are part of your abdominals, your internal obliques and transverse. So there's, again, all of these are muscles of the abdominal area. So each of these muscles can be impacted through ALS and MND. I'm just going to pause for a sec. I do apologize. I've lost where my camera is. There it is. Sorry. So it's important to understand how breathing is affected. So what we see in ALS MND, as the diaphragm does become weak over time, and it does make it a bit harder to take deeper breaths. So we struggle a little bit to get that volume in. We also have a reduced lung capacity, which is the amount of volume that we can get both in and out. So people might notice that taking a deep breath actually also becomes more tiring because we need the muscles to contract in order to take that breath. The breathing may feel a bit less efficient, but as we're going to talk through today, there are many supportive strategies and tools available to help with the efficiency of the breathing. You might notice that your cough, like people's coughs, are not as strong when we start developing a little bit more weakness as a result of the condition. But there are devices, and again, we're going to touch on these to help clear mucus effectively. And I think the most important part, I think, in regards to monitoring respiratory status is just making sure that we're having regular checks, regular self-checks, but regular checks with any professionals that we're involved with, and to help make the right decisions at the right time and to manage the changes as they come. So signs and symptoms that you may experience of respiratory compromise. So these are the things or early signs that people might see. So shortness of breath doing different activities or activities that wouldn't normally have given you shortness of breath. Morning headaches or frequent waking during the night. Reduced cough strength, and you can notice the sound of the cough to sound a lot weaker. More frequent respiratory infections. Feeling tired during simple activities, because if the muscles are weaker, but they still have to contribute to breathing, breathing can actually become quite an effortful thing. People might notice shallower or faster breathing, changes to voice or feeling breathless when speaking, as well as frequent yawning or sighing. So these are definitely the things to kind of look out for yourself. There are also some self-monitoring tools that I'd like to also chat about. So one that I really like is called the SYNQ5 questionnaire. And this one's a really great, it's just a 5-step questionnaire that you can ask yourself these questions or talk to your healthcare professional about. It actually has been shown to flag up the developing of diaphragm weakness. So the 5 questions are: do you feel breathless if you lie down? Do you feel breathless if you bend forward? Do you feel breathless if you swim in water or lay in a bath? Have you changed your position in bed because of your breathing to make it more comfortable? And lastly, have you noticed a change in your sleep? So are you waking more, getting up tired in the morning, those headaches in the morning, and generally just poor quality sleep? The other things that we can do at home are just monitoring our own oxygen levels. There are pulse oximeters that you can get online relatively cheaply, or most chemists I know in Australia, we stock them in our chemists here. They can range anywhere from like $5-10 up to some pretty full-on ones. But they're really great just to monitor oxygen levels at home, and aiming to keep that above 95%. And again, if it starts to drop below 95%, then that's kind of a trigger to go and have a chat to whoever's part of your health team. And lastly, a peak cough flow. This is, I don't think I put a picture in. I may have. Peak cough flows are a really great, quick and easy measure of the strength of the respiratory muscles, but also the strength of the cough. So the peak cough flow there are some very specific numbers around peak cough flow. And this ties into when we also have a chat about the cough assist devices. So people, if peak cough flow is below 180 litres per minute, and this is it's in the literature very strongly, that individual definitely needs some form of mechanical support for their coughing to make sure it's strong enough. If someone's peak cough flow is somewhere between 180 and 270 litres per minute, they might just need additional strategies like breath stacking strategies. I know Angélique mentioned breath stacking in her video to start with, through like a bag system or something like a sip and puff ventilation to try and just give it that little bit more oomph. And peak cough flows over 270 is something that you don't really need to be worried about or intervene in. So they just are they're a really simple device. They generally cost around $10 or $15 Australian dollars, keep that in mind. And you literally just take a really deep breath into it, and you can either blow, cough, or huff really hard, and this little dial on the front will just zoom up, and then it gives you a number. So that can be really helpful. There are some more formal monitoring tools as well. So lung function testing can give us a really good understanding of where someone is from a baseline perspective, but also if we're getting tested semi-regularly, so some people go every 3 to 6 months, then we can get an idea of how that lung function is trending. Lung function tests can be really important in regards to decision-making around interventions like PEGs as well as if somebody is choosing to go down the road of a tracheostomy, because lung function is a determinant of anesthetic risk as well. We can also have a look at inspiratory and expiratory muscle training or strength training. So snips and bips can be done to have a look at how strong the diaphragm is. And if we're seeing a little bit of a drop, we could choose to do some respiratory muscle strength training in that space. We can also have overnight oxygen levels to have a look at sleep disordered breathing or nocturnal hypoventilation. And lastly, sleep studies can also flag up if we are having difficulties with our breathing as we sleep. So the next session I wanted to touch on is the management of oral secretions. So oral secretions or drooling occurs not due to the fact that the body is producing excessive saliva, but it's more around our ability with the use of the tongue and muscles in the back of the throat to actually manage the saliva when it is produced. So we do find that it tends to drool because we do have a hard time gathering it up because it's such a, well, it sounds weird to say, it's such a liquid. It's not thick or anything. It's really hard for the tongue to gather, especially if we're developing any sort of tongue weakness. So we can also develop a buildup of saliva and thick mucus. And some people have noticed that it definitely can disrupt their sleep and increase the risk of choking or the feeling that they're choking. So what do we do? So there are pharmacological management strategies. So there are medications such as anticholinergics or atropine drops. Atropine drops are actually eye drops that can be used in the mouth every 4 hourly to try and assist in just drying up some of the oral secretion and drooling. There are different medications like Buscopan and scopoderm patches that can be worn behind the ears. They're more related to they're like more travel sickness medications, but they can dry up oral secretions a bit. We then jump up into glycopyrrolate, which is quite a strong medication to dry up oral secretions. But what I tend to find with things like glycopyrrolate is they also, because it's a systemic drug, it not just works in the mouth, it also works in the back of the throat and the rest of the lung tree. So sometimes we do then have to counter other symptoms like thicker mucus coming up from the lungs. Some tricyclic antidepressants like amitriptyline, they can use the side effects of these kinds of medication, and the side effects are a dry mouth to dry up oral secretions, and Botox injections. We've only just started here in my town, Launceston in Tasmania, doing some Botox injections for excessive drooling for our clients. So it's new to me as a clinician, but I'm really excited to see where that goes. We also have non-pharmacological management for oral secretions. So positioning, it can be very important. I do have a lot of clients that we do support their head and neck, or they are in a little bit more of a forward position just to allow it to come out of the mouth. We also need to be mindful of skincare, because if the drilling comes down the sides and we're constantly wiping it away, we can get very red and sore around the sides of the mouth. And thirdly, there are suction devices that can use to kind of suck it out, suck the mucus out of the mouth and the back of the throat. So other ways to, so things like dehydration, mouth breathing, and evaporation of saliva can also cause thick mucus to build up in the mouth and at the back of the throat. And if you combine this with a weakened cough, this can be quite distressing for people. So there are some definite things that we can do around how to manage the thicker mucus and saliva. So increasing fluid intake and water intake to try and break it down. Mucolytics are also a way. So there are multiple kinds of mucolytics. So things like grape juice, pineapple juice, and papaya have a enzyme called bromelain in them, and bromelain has been found to break down the thickness of secretions in the lungs. Normal saline nebulizers can be really great, like that kind of steam inhalation therapy. Bromhexine is another medication, and N-acetylcysteine can also break down the thickness of secretions. And I am mindful that these are drug names that we use in Australia, so they might be different wherever you are living. Mouth care can also help. So really having really great oral care through either swabbing or brushing our teeth on a regular basis can also help with the thick saliva, as well as things like an assisted cough. So assisting the cough to get a little bit stronger through things like breath stacking, or even physically, and I can touch on this a bit later, but physically compressing the chest wall or the abdominal area as somebody goes to cough, can actually boost the strength of their cough to try and move some of that thick mucus or saliva from the back of their throat. So the next thing I want to touch on is respiratory muscle training. It's a relatively new area in MND, but it's also is showing a bit of promise in regards to assisting maintaining of lung function. So there are certain things that we found out about respiratory muscle training. And again, I'm blessed to talk about this actually tomorrow night. So respiratory muscle training is using devices, and I can show you, I'll show you just what one may look like. So this is one type of respiratory muscle training device, and this one helps to strengthen the muscles on the in-breath. And there are also different devices that can strengthen muscles on the out-breath. And what we found is that it is a good thing to start early on in an MND journey. We get the best results in those early phases when the lung function is about 80% or above. So IMT, or inspiratory muscle training, has been shown to show the rate of respiratory function decline in ALS and MND compared to when we look at controls or in studies or people who have not had the treatment. Expiratory muscle training, so blowing out against a resistance, has been shown to help with swallowing function and also speech function. And a combination of doing the two together has also been shown to maintain peak cough flow throughout the course of the condition. So when we do this type of training, and I know that there was a question around respiratory muscle training and how to teach. So we do like to train at about 30 to 50% of the maximum inspiratory pressure that somebody can do. So this is either from a formal assessment of a SNP and or a MIP. A SNP is the SNPs and MIPs are your one repetition max of you breathing in as quickly and strongly as you can, having a look at the strength of the diaphragm. So, and that will give you a specific number. And then it's looking at training around 30 to 50% of that specific number. It is recommended to do 5 sets of 5 repetitions 2 to 3 times per day. So I really wanted to touch on mouthpiece ventilation, and Angélique, feel free to chime in at any point. I think I've only got one slide on this today, just because of time. So mouthpiece ventilation is mainly used for people who are becoming more breathless in the daytime, and they might also have the NIV overnight. And as you can see in the image, and as you can see on Angélique, there is actually a ventilator that is on the back of the wheelchairs. And then there is an arm that comes up as well. So this arm that comes up to the mouth to a mouthpiece. And then the ventilators are generally set on what's called volume control mode. So it can deliver a set volume. So it might be like 200 mils, 300 mils, 400 mils, depending on what that person needs. So then, as you can see, Angélique, she will either take a suck on the mouthpiece, which will trigger the ventilator to give her a top-up breath. Or there are devices where all people have to do is like place their tongue onto pretty much like a straw on the end, and then because you've occluded it, that triggers the ventilator to deliver a breath. So it can be really great to help with the feeling of breathlessness during the day. It can also help to blow off carbon dioxide if somebody is retaining carbon dioxide throughout the day, because that retaining carbon dioxide can cause things like lightheadedness and dizziness. It can also help with pressure area management. So if you're on NIV and you're getting sort of redness and pressure areas, either the bridge of your nose, around the bottom, or the chin, it can definitely give us a break from non-invasive ventilation. And it can also help to support speech as well. So in order to speak and speak clearly and get 3, 4, 5 words out, then we need to have that deep breath in before speaking. So it can definitely help with speech as well as fatigue. Angélique, did you want to touch on anything at all in that? Nope. Okay. Beautiful. I must have covered it. All right, so let's just jump into cough assist devices. So a cough assist it is a machine that the goal of the machine is to clear secretions, and by gradually applying a positive pressure into the airways, which then is quickly shifted into negative pressure. So essentially what we're doing is the machine is giving the person a deep in-breath, and then very quickly it switches and sucks the air out of the lungs. And with that quick switch and the suck, it then helps to increase the strength of that person's cough and the effectiveness of the cough. So it has been shown to improve inspiratory volumes and the peak cough flow. So remember when I touched on the peak cough flow meter, it can increase that number on that monitoring device. So there are benefits can be limited with people who do have quite strong bulbar symptoms. The treatment can be altered when you look at the studies. The treatment can be altered in different ways, such as applying very low flow rates through the machine, or seeing if the machine, as the person receiving the treatment, if they can actually trigger the machine to deliver the breath. So those two techniques have actually been shown to try and get around the challenges that we see with bulbar symptoms. So there was a really great study that was done that looked at, they put a camera down people's sort of throats who had bulbar symptoms, who were getting cough assist, and what they found is if when we deliver the positive pressure or the in-breath, the vocal cords actually wanted to close together. So, which then meant that the treatment can be ineffective. So by getting the machine to be patient triggered and also changing the flow rates to nice and low, they found that the vocal folds will actually stay open. So that's just a couple of little tricks as well for you. The things I found in my experience working with these devices, that generally people like myself who use these devices all the time will set the pressures and the treatment for the person that we prescribed it for, and then it can be safely used at home after that point, because we've set the safe pressures, we know we're not going to harm the person. So the goal of the cough assist machines are to help shift mucus and make the cough a lot stronger, which means that it's more effective and reduce fatigue. So these are some of the cough assist devices that are on the market in Australia. So just so you just have an idea of what you're looking at, or if you start Googling, then you can have a squizzy. So I have experience with the Philips cough assist devices, which I know like we can't get them anymore in Australia, but I definitely know that they're still like in America. The Pegaso down on the bottom left-hand corner, this guy is actually Italian. We're lucky enough to be able to get them imported into Australia. The Kalos is one I've not used before, and the Nippy is also, it has lots of multiple functions. So we're really dependent on the advice that you're getting from your respiratory therapist in order to pick the right one for the right reasons. So these devices are mainly used with a face mask, but they can also be attached onto a tracheostomy if somebody has a trachea. Some of them come with battery use, which are important to probably check out when making a decision around these, because if you do need to travel or go anywhere, or there's a power source problem that and you still need the cough assist machine, then knowing that it has a battery life is very important. We also need to make sure, because these are obviously plugged into a power source, that we have a reliable power source when considering their use, as well as we need to consider the cost of consumables, which generally get replaced on a monthly basis, which are the consumables and the mask and the tubing. Nothing needs to happen in regards to the machine itself, and they're actually quite long-lasting devices. So the other thing to consider is also because we do need to either attach it onto a tracheostomy or hold the mask over the face, that we need to either, if we're losing hand function because of MND, then we might definitely need some help from family or supports to use these devices. When we do, if these kinds of devices can also be used for like preventative care throughout the day, when we are feeling well from a respiratory perspective. But when we do, and if we become unwell with a chest infection, the settings do generally need to change and they need to go up to support the fact that we're probably going to be experiencing fatigue with a chest infection. And I did mention just before that each device does have like different functions as well. So definitely have a chat to whoever is around you who has that experience to see which one is going to help. So we're going to now jump into non-invasive ventilation. So non-invasive ventilation, there is evidence that supports the use of NIV in MND to improve the quality of life and meaningful life as well. It can maintain lung function, and studies have shown that it can assist in increasing life in regards to up to 2 years if started relatively early. So NIV can help to address and alleviate symptoms such as carbon dioxide retention, fatigue and tiredness, poor sleep overnight, as well as the sensation of breathlessness. There are 2 types of non-invasive ventilation, which are really important to understand because there's mainly one particular type that we use in motor neuron disease. So it's important that we maybe don't get put on the wrong one. So CPAP is one type of non-invasive ventilation. It's mainly actually used for obstructive sleep apnea, and it's not commonly used in MND. CPAP only delivers one continuous pressure throughout your in-breath as well as your out-breath. So if we then develop respiratory muscle weakness, it can become a problem because the pressure then becomes too high for us to exhale properly. But that's where BiPAP is the preferred NIV option. BiPAP then delivers one pressure which is higher as you breathe in, and then a lower pressure as you exhale, which allows you to blow out against that pressure, but also to dump off some carbon dioxide. So both are delivered by a mask, or as you can see in the pictures, the top picture, the gentleman has a undernose, but it's called a full face mask. The lady has a nair, and the gentleman has a traditional full face mask that goes over the bridge of the nose. People who, if we do have the full face mask over the bridge of the nose, we do just need to be very careful about pressure area development, and it can come on very quickly. So within 24, 48 hours of people having it, even just like if they're using it for sleep and overnight, you might wake up one morning and there's a bit of redness, but then if you go back and treat again with the same mask, you might actually get skin breakdown the next day. So I generally recommend people to have 2 available options if they've got this mask, to also maybe have a backup option for the underneath as well, just in case a pressure area develops. So there are some parameters to assist us in understanding when to start non-invasive ventilation. So the most important thing though before starting is to really have a really good conversation with the healthcare team and family, and as a unit deciding if this is the direction that you want to go in, because non-invasive ventilation, it starts off as a treatment to assist with fatigue, but as the condition progresses, the reason for being on non-invasive ventilation changes, and it actually becomes, as the title says, a formal mode of ventilation. So to start, there are formal indicators for non-invasive ventilation. So an FVC or a forced vital capacity or a vital capacity. And these are things that are found on spirometry or lung function tests. So a forced vital capacity, just so you're aware, is the amount of air that somebody forces out of their lungs after a deep breath in. And vital capacity is literally the volume of air that you can get both in during a really big in breath, but also added to the amount of air you can get out on a really big out breath. So if either one of those is less than 50% of the predicted value, then that is an indicator to start NIV. If someone has an FVC or vital capacity less than 80% of predicted, plus symptoms or signs of respiratory distress or orthopnea, which is shortness of breath when you're laying down, then it can also be started. SNPs or MIPs, which are the strength training for your strength testing for your breathing muscles, if they are less than 40 centimeters of water pressure, or if they are less than 65 for men or 55 for women, plus any symptoms. So the other question around this is also, yes, when to start, but when to stop as well. And this is where it's super important to have really strong conversations around NIV, because ultimately when we start, it then becomes a decision around the elective removal of BiPAP. And that is essentially the day that the person who is on NIV is going to choose for that mask to come off their face, be made very comfortable, and then pass away. So these are very serious conversations when making decisions around them. So there are some logistics that we need to be mindful of in regards to NIV. So we need to consider how the NIV will work if the person can only say come off NIV for short periods of time for 1 to 5 minutes. How does that work with things like personal care, getting dressed, showers, and things like that? Because the device is also pushing in air into the lungs, we also need to have really good oral care as well. It can be a little bit drying for the mouth. So lots of good teeth brushing and swabbing may be needed to keep the mouth moist. Sometimes people need medications such as morphine or oral morphine to be able to come off the NIV, because the morphine can actually assist in reducing their sensation of breathlessness. For example, again, if they need to have their oral care done, or they want to come off for a shower or something, or just to wipe their face or clean their face, then that needs to be considered. Excuse me. I've been talking flat out. We also need to consider the consumables as well, masks and tubing, having a reliable power source and or batteries for travel. Non-invasive ventilation, there are little travel ones available on the market, which can be they're just nice and small and portable. Some people also we need to consider whether or not if somebody needs more than one machine in their home, especially if they're on it for really long periods throughout the day and out throughout the night, just in case something happens to one machine. And I have had clients who've had, say, one machine in their bedroom and a second machine that lives in their lounge room as well, just from a day-to-day logistical perspective. We need to be careful of pressure area management, and the person also may need support if they're still taking oral intake at that time as well, eating and drinking. So to pause the machine for that to occur. So let's touch on tracheostomies in motor neuron disease. So a tracheostomy is an opening in the windpipe, which is made via a surgical operation. So as you can see from the picture on the right-hand side, The tracheostomy, you can sort of feel where your vocal cords are, and a tracheostomy tends to come just into this space down here. And it is essentially it's like a little plastic tube, which then gets inserted through the hole, which is then connected onto a mechanical ventilator to assist with the breathing. There are definite advantages that come with tracheostomies. So it can liberate people from NIV mask and pressure sores. So if somebody is on NIV 24 hours a day, they may choose to go on to have a tracheostomy and formal mode of ventilation, just to alleviate, they might have quite terrible pressure sores from the mask. It can actually give us better access to lower airway secretions. And again, if somebody has very severe bulbar symptoms, it can allow us to, do things like suctioning or cough assist to kind of mobilize stuff from further down the lungs. We do see a reduction in aspiration risk on oral secretions, because I'm not sure if you noticed that in the tube, there is a little balloon that holds the tracheostomy in place. And so essentially oral secretions end up just sitting on top of that. And generally we don't see as much drooling as well. There is the potential for a longer life expectancy. And it is an effective form of ventilation for severe bulbar dysfunction. There are also disadvantages and things that we need to be mindful of with tracheostomies. They do tend to come with prolonged hospital stays, and obviously we're now working with a ventilator and understanding the complexities of a ventilator. So everything becomes quite medicalized in this space as well. And then we're looking at making sure that we have the support and staff of quite highly qualified people to make sure that this goes safely. Going home, depending on where you live and what supports and available resources you have, may not be possible. There is a risk of the tracheostomy coming out, but those sorts of risks are also managed. Generally, surgical tracheostomies are stitched in place, so the risk is relatively low, but it does exist. And again, high care and equipment needs. There can also be difficulties in speaking as well when we get onto a tracheostomy. There are, depending on if somebody does or does not have bulbar symptoms, that they might want to try a speaking valve, but a speaking valve does require a significant amount of muscle use. So it may, whilst the people are probably happy to try that it may not actually allow them to speak. Some of the risks and considerations that we need to take into account is with a tracheostomy and ventilation that this person now needs to be watched 24 hours a day, 7 days a week, because there is an increased risk now of mucus plugging in the tracheostomy, and that's a very serious problem. And if that happens, it needs immediate attention. We also need to be close to a regular power supply in regards to the ventilator itself. They do, most ventilators do have battery backup, but they're only there for essentially in emergencies to get you to a regular power supply. There is, again, a high risk with having a trachea and a ventilator of developing ventilator-associated pneumonia. And that risk is a lot higher with a tracheostomy compared to non-invasive ventilation. The need for a suction unit also increases. So in order to get the mucus out from within the lungs, we need to have to be able to perform deep suction through the tracheostomy. And there will be consumables to the eyeballs as well in regards to having a tracheostomy. So resources and funding need to be looked at. Oral care also needs to be heavily maintained as well, because when we start breathing through this tube, we're not doing the same normal breathing and routine around the mouth. So the image on the left here, so this is a type of tracheostomy. So you can see the little balloon around the bottom of it. And these can also come with little suction attachments, which are part of the tracheostomy. And that allows for any secretions that get caught above the cuff, that they can be sucked out. The image in the middle is essentially it's like a T-piece that on one side, we've got the tracheostomy at the top, and then coming across, that part is attached onto the ventilator, so delivering the breath. And then the silvery sort of loop that comes down, that is the suction. So you can feed that long catheter down through the trachea and down to sort of either trigger a reflexive cough, or to get secretions that have built up in your trachea. So there can be an inline suction unit connected to be able to perform a deep suction. And oral secretions, if the person is making them, can be managed with medication and above suction attachment. And that's everything. And I think I've gone relatively to time.
This has been wonderful. Thank you very much, Susan. There has a lot of information. Can I ask you to stop sharing for a moment so that we can see them? Brilliant.
I'm going to find how I do that. I think I might. There we go.
No, you're still sharing. Let me just see.
Okay. Has that fixed it? Oh, try that one.
Perfect. Excellent. Thank you. So no, you had a difficult task because there was a lot of information to cover in a very short time, and I appreciate you were able to answer a lot of the questions that we had received earlier on throughout the presentation. I do have a few questions, so we've got like 5 minutes that we can cover. So I'm going to give a heads up to Angélique so she can start thinking about this answer. Do you have, like some final words or a top recommendation you want to give people living with ALS about sort of what to consider for their respiratory health as living with ALS? So I'll just give you a few minutes, Angélique, to get your thoughts together on that one. So we've got a question there where they were asking about nebulizers. So can you just, quickly touch on the use of nebulizers for respiratory care, please?
Yeah, so nebulizers have a place, I would say, in two ways. One, to deliver medication to help open up the airways. So the use of things like bronchodilators. You don't normally see them unless the use of like bronchodilators unless somebody has a pre-existing maybe asthma or COPD. They can also be really effective if somebody is unwell to deliver medications directly into the lungs. And they can be helpful to break down the thickness of mucus if people want to put like normal saline into them, which is essentially wound wash or eye wash. It's generally readily available. Or you can put things like hypertonic saline, which have a little bit more of the salt solution to them, just to break down the mucus. So essentially it just helps. It's a device that creates essentially steam of whatever sort of liquid that you've placed into it.
Great, thank you. And I see a comment on the chat, and I know you mentioned on it briefly, but in the event of an emergency or thinking of being prepared, for example, if there's an evacuation, power outages, or even the battery life of any respiratory equipment, are there any recommendations you can give in the essence of being prepared?
That's probably a really big topic, but I do recall, Jessica, there was a gentleman in Basel who did a great presentation on this, and he even developed, I think, like a checklist of things to have. So that might be probably a better resource.
Oh, yeah. Okay. So thanks for the plug. So that was the Alliance's emergency preparedness. That wasn't planned, everyone. So yeah, so I'll just complement that. So in the Alliance website, you can actually find the checklist of what to be considered. But it is important. I guess the message is that if you are dependent of a ventilator of some sort, that they should consider what to do if they were presented with an emergency. I see here on the chat, someone's commented that emergency ventilator power supply using a car battery lasts 2 days for extended power outage due to hurricanes or tropical storms. So thanks, Lynn, for sharing that with us. So if the oxygen levels are under 95, and getting an appointment is not an immediate action they can do because of whatever limitations or what should be the next step for what should be the action if their oxygen levels are low?
It's really dependent on whether or not the person is symptomatic. So it is actually safe for us to live with oxygen levels below 95, and especially they've sort of crept down towards 95. Our body does compensate with a slightly lower. You know, you would start to escalate the appointment if the person was starting to get down towards like 92, 90, 88. But at 95, it's more of a flag to then start to address early, before we sort of get to 92, 90 level, that to sort of start to be prompting that medical team, trying to get those appointments, probably knowing that they might be 6 months away or 3 months away to go and see someone. So it's just trying to help in that prepared nature. But you don't need to, if your oxygen is at 95, we don't need to stress about it too much. We're still very safe. We still have plentiful oxygen running around the body for all of our organs.
Okay. That's great. Thank you so much. I'll let you rest your voice because I know it's been an intense hour. Angélique, so I've given you time to think. So what would you say, do you have any words or recommendations that you want to share other people living with ALS for them to consider and think about?
I would say start in time by getting used to ventilation, because it was a little bit scary for me, and I pushed it away. So start in time. That's really my suggestion.
Thank you, Angélique. And Susan, before we wrap up, do you have any final words or any final recommendations you want to share with our audience? Or do you feel you've covered as much as you can?
I think at this point I've probably covered as much as I can.
That's fair enough. So I just want to quickly I want to invite everyone, if you haven't already, to subscribe to our newsletter. And on behalf of the Alliance, I want to say thank you to Susan and Angélique. A lot was covered today on respiratory support in ALS MND. And for many of you, there is a lot to process and you will have more questions. But we hope with the information shared today, it will equip you to inquire further with your medical team about the options available to you and be informed so that you can be prepared and make the decisions that are right for you. We also want to say thank you to our sponsor, Mitsubishi Tanabe Pharma, who makes this webinar series possible. And of course, a big thank you to our audience for joining us today. I want to wish you all a great morning, afternoon, evening, depending on where you are in the world. And again, thank you, Susan, and thank you, Angélique, for sharing and spending the time with us today. Thank you.